It gives me great pleasure, and I've sort of probably already alluded to this earlier on, to introduce Joe Rafferty, who is a clinician by background, but has been one of the longest serving and probably one of the most successful chief execs in the country that I've known of. He's been listed in the HSJ, and he comes in within the top 10 chief execs in the country. Now, this is a man who likes being a chief exec of a trust within the community, and Joe is here to stay. He leads an organization which is a global digital exemplar, which Keith alluded to, and Joe is here to tell us about how to replace tablets with a tablet. Joe Rafferty.
Thank you very much, Raj, for that, and thank you very much for the invitation to come along today. Over 15 years ago, I think I met Raj, and he had a massive vision about a clinical leaders network, and it's been great to be in on early on that, and to see the massive achievement that Raj has made. So, a bit of fun. Can we replace one tablet with another? But it's not probably a completely outrageous proposition. But I just want to start with a bit of context for us, and so why is digital so important? And I mean to us, a mental health trust. Well, we have an unprecedented focus on mental health at the minute. You know, we had an election where all three parties were squabbling over who was going to say the most about mental health. But of course, there are lots of competing priorities, and somebody said to me the other day, it's great to be in mental health because the tide's coming in. And I had to say, but remember, the tide goes out as well. So we've got a short, narrow window, and we need to articulate the case to allow politicians to justify the rightful emphasis, in my view, on behavioural health. Attract research funding. We're about 24% of all of the activities, 12% of the money, and 4% of the research. That's terrible, but actually we're 4% of the research because we're not organising our data. We're in little small units stuck all over the place, not really thinking about how we take this big data opportunity and do things differently. We have, we think, probably quite a lot of evidence-based interventions, but are we applying those rigorously? So what we think happens, is it really happening on the shop floor? And the gap between what we think happens and what actually happens, I think, is probably bigger in mental health than it is in equivalent physical health services. And then, are we ready to benefit from new and emerging technologies, of which there are many? So to articulate the case, we need robust, reliable, and reproducible data. And that, for most mental health trusts, is a significant challenge. And to achieve the digital revolution that I think we're all desperate to see come along, I think it's a front and center activity. It's not a nice to have. I think by definition, we're probably a self-selected group of people here today who are in the leading edge, the people who will articulate the positive benefits of all of this. But the critical issue is, how do we get into the middle, and how do we get into the 20% of people who think that this is just, you know, too hard to do? So my argument is, it's really important that we all, but particularly leadership in organizations, boards, chief executives, chief clinical information officers, all of those people, do everything to make this a front and center activity. So it should be relevant to every clinician in the organization. So that's a bit about this being important to us. I'll tell you a bit about Mersey Care, our digital ambition, our key deliverables, and a bit about how we learn and share. Our footprint is at one level, you see in the middle, it's 4 local authority regions based in and around Liverpool. But actually we provide a broad range of secure services, including high secure, for 1/3 of the country. So the green area is our catchment area for high secure services. So it's about 1/3 of England and all of Wales. And then if you go to the left-hand side diagram, we're spread across probably about 35 sites. So it's very different from a single hospital site. It's very different in the spread of what we do, which is everything from almost pre-primary care coaching of people through to high secure services. And this means we've got to take, I think, a very different approach to how we develop services in the future as we go. David made a very interesting point this morning about a demand-led system rather than a supply-led system, and I think that's exactly where we want to be in this. I'm not going to go through this, but on the left, that major driver of deprivation is absolutely critical in the services we provide, and it destroys people's lives. It destroys people's lives in a reproducible way. And we need to be able to do something very different to make the impact of that deprivation look really different in terms of these sorts of outcomes. And interestingly, if you think about it, a lot of the data that we would capture to drive a different paradigm actually isn't in the NHS, because an awful lot of the stuff the deprivation that deprives this isn't within the gift of the NHS to solve. So for us, one of the big lessons around the mental health digital exemplar is we need to be reaching into local government, police systems, social care, schools, housing. I mean, it's the myriad's endless, really. But our key strategy for tackling these challenges is a bit, I suppose this is a different way of talking about Keith's triple aim. He talked about efficiency without quality is unthinkable. Yet quality without efficiency is just unsustainable. So we've tried to think about that triple aim, to fly right down the middle of this and think about how we handle this in this really complex and challenging world we're in. And our approach has been to really have a very, very clear view of what we want to achieve. That's articulated in the circle here. Clear focus on quality, clear focus on our people, so patients and our staff, two critical domains, our research and our future. You'll notice in our resources, we have technology that helps us provide better care. And we've been working on this circle for over 5 years, and I'm really pleased to say 4 years ago, we took a digital strategy to our board. So when Keith then talked about mental health digital exemplars, this was what we've been waiting on. So clearly we see the GDE as able to drive our strategy, not that the GDE, our strategy will drive our relationship to our GDE, not the GDE will drive our strategy in that sense. And the thing that we've done is set ourselves some big, hairy, audacious goals, which is making us think differently, and is therefore going to make us shape our services and how we organise those services and do things differently. So perfect care, it's been a not uncontroversial thing to say, but everybody in our organisation who's treated in the organisation should receive perfect care. So very, very, very low error rates, huge ambition. And we sort of articulated this by saying we'll reduce deaths by suicide for people in our care to 0 in the next few years. That's a huge, hairy, audacious goal. And the second thing, we'll eliminate physical and medication-led restraint in our services very, very soon. So two big, hairy, audacious goals that absolutely challenge the organisation to its core. And I think this is probably, in mental health terms, the moment when we said we're going to get rid of central line infections and the mortality associated with coronary artery bypass graft and all of those things. So I think in a sense this is mental health coming to that point. And we mediate that through operational excellence in an open, just and learning culture. So I tell you that because it's really important to understand this as the backdrop to what we're trying to achieve, because all the digital stuff is about trying to push us in this direction. It's not just the fun of the digital stuff. And critically, this is how we're approaching things. The middle bit about practices, I think, is where most people go in. I think probably the Connecting for Health programme went in there as well. Change practices to achieve desired outcomes, not unlaudable in its own right, but actually you need to really go to the far end. What is it that we want to achieve? And then around the practices, you've got to have the concept of accountability, the concept of your capabilities, and right over on the other side, your mindsets, because this is massively challenging. Maybe not for you guys, but think of the half dozen of your colleagues who will be, not enthusiastic about this. But we need a mechanism to make them enthusiastic about this. So we do this against this whole range of activities. So where we come at this is thinking about foresight, so 0 suicide and 0 restraint in this instance. Insight, so listening to understand, co-production. We talk about patient engagement. I don't think that quite does it. I mean, patient engagement, I think, is often about listening to patients so that we can react to the next thing to do. We were doing that a long time ago, I think, in Mersey Care, and we've moved now to listening to understand, and that's a completely different approach. Talk about it later. And finally, oversight. You can only do this where there's openness, transparency, and candor. Again, I was very, very taken by Martin's comment this morning about the potential dangers in this. And we need to feel safe. You need to feel safe as you engage in not only tackling those big, hairy, audacious goals, but laying in the digital opportunity that will get us to those places. So this is what it feels like. It's a version, again, I think probably of Keith's slide. I'm reminded of Nate Silver and, you know, the signal to noise. And intelligent people can pick up 5 bits of information at any one time. I'm amazed, actually, when I see what lots of our clinicians do in that cacophony of noise, really, how we keep managing to pick out the bits that matter. But equally, I can also understand how from time to time we miss the bits that matter as well. So our solution to this, the digital ambition, is against the backdrop of high levels of digital exclusion. 19% of people in Liverpool haven't used the internet, have never been online. So it's massively digitally deprived. And we talk about in our patient population the most vulnerable excluded people in society. Some people who, if they're in our services for long enough, can be digitally deprived. So people who might have been in our services and yet never seen or held an iPhone. Can you imagine that? And what we want to do is transform to a system that is predicting rather than reacting. One that provides quicker access to services. So we know the current millennials value access over ownership by a huge amount. So access will drive, will be the demand from the people in our population who in future will provide services for. Safer contacts, clearer outcomes, more control over your own health, really important in the mental health sphere. So we know that so much of what happens in mental health relates to what happens in everyday life. And actually being able to control those things in a different way is hugely important. And that enables sustainable recovery for life beyond diagnosis. So if you've suffered a period of depression, why should that define you for the rest of your life? Why should type 1 diabetes define you for the rest of your life? You've got to have life beyond diagnosis. And I think this should wrap up inside our digital ambition. So what do we want to do? 2 things. Flip the clinic. So we want to use digital technology, patient-owned records, access to expert clinicians, alert mechanisms, behavioural triggers, enabling self-care so that we can provide our services where the person is, not where we have to bring them to. And I'll show you how we're starting to do this in a second. And then our view is digitisation is about people, not just technology. In fact, if it's not about people, it doesn't matter about the technology. So co-production for us, co-production with service users, in a way where we are genuinely side by side on that. So nobody is really leading that. It's true co-production. Digital skills for our workforce, and this critical thing about making it safe to fail, but to learn the next time. So how can we achieve this? So we think a framework that goes record, monitor, predict, and respond with analytics engines at the middle. And just to talk about this for a second, a predictive analytic engine so that we move from dashboards that are predictive rather than ones that are reactive. At the minute, all of ours are largely reactive, and it feels to me like you're trying to drive down the motorway and the only thing you can do is look in your rearview mirror to see what's ahead. So it's a bit of a spooky business in many respects. So can we start to look to where we're going? So this is work we've been doing recently, and it looks at risk of crisis by stratifying into different high, medium, etc. Risks of crisis, and then using an algorithm to first of all look at the concordance between what our clinicians thought the risk of somebody going into crisis was and what the algorithm actually predicted. And you can see that the high risk, that we're the middle of the pink ones. The right-hand side is probably the cleanest mental health data set in the country. The left hand is just a comparison. But 73% of every time we looked to use the predictive algorithm, that matched what our clinicians thought was going to happen to that patient. And then if you look at the medium to high risk, you add that figure in, you're starting to touch 90%, which is pretty good. And so if you look at the risk of crisis analysis, you can see really good concordance between what the predictive algorithm goes for and what our clinicians thought might happen. And that becomes a really interesting moment for us so that we can move into, don't really worry about what's on here in a sense, but it starts, first of all, to allow our clinicians to look at a patient in one swoop. So we can see everything that we need to see at one moment in time about the system. So the number of people waiting, the number of people receiving treatment. Critically in that third line down, who needs today to be stepped up to a higher level of care and who needs actually to be stepped down. And we probably know these things, but we don't know them in close enough to real time. And our system sort of churns too slowly. So we reckon that to get, if I go to the next one, which is actually about the individuals. So contact history, healthcare worker, the risk of crisis, and then on that right-hand side, all the multi-agency stuff that's important for mental health, all in one place. Our sort of estimates at this stage say it would take us about 3 hours for any of our doctors to be able to get all of this stuff on the screen, to be able to make the judgment. So now we can get it on the screen in minutes rather than hours. There was a question earlier on today about how do we get people engaged in this? Well, if I can give you 3 hours back, every time you sit down, that's a pretty good incentive to be getting on with this. And then we can go right down to any one individual and start to, at a glance, take a look at what we need to do. So think about it. This is all about crisis services. And it's really interesting, isn't it? That's a bit like saying we have somebody who clears the train crash up. It feels like it's the wrong solution to the problem. So we shouldn't have the train crashes. So what this allows us to do is start to go backwards. Can we get the predictive analytics to start to begin to say, put a flag on this so that we can quickly understand, when somebody is low to medium risk of crisis, before they start to trigger, can we do something about it? So really different approach for us. Can we record differently? If you look at the grey line, it's what happens now to patients. If you look at the line above, it's a totally different journey for the patient. Recovery navigators, recovery teams, really thinking about the risk of relapse in a completely different way. And this becomes for us the preferred journey rather than the one we see. So we need to be thinking about recording the sorts of data in future that will keep us on the yellow line rather than the grey one. And our new clinical information system with our support colleagues here is designed really to make sure that the pathways we think we're delivering are actually the pathways that are being delivered. And this is a huge part about taking that variation out of what happens every day and putting the evidence right in the place we need to have it. Monitoring, there's more I can do in that, but I wanted to go to this one, prediction. So we work with the Risk Authority in Stanford around natural language processing, artificial intelligence and so on. And they have a tool, it's called, and the tool produces data science opportunities. And it runs into a value-creating risk framework. But, we've started to push bits and pieces of information into this. And I'll talk about a couple of the opportunities with this. But one is to think about predictive analytics in terms of the risk of self-harm or suicide and begin to trigger alerts. So if we have that natural language processing ability, and we have an initial score on the left-hand side calculated for a patient, and then we can look at, for example, mildly negative comments on Facebook. So this is about reaching beyond clinical records and into people's more private space. But actually, we're discovering that people say different things in social media than what they say in the clinic. So it's a really important way of cross-referencing. Negative comments in a journal, low mood score meter, and eventually, if we pass through a threshold, the app will call the relative authorities. But really what would be powerful in this is when the patient themselves reaches P2, they reach out for the services. And this isn't what we call vaporware, so this is built, it's done, and it's in trials in Mersey Care at the minute. So this is the opportunity with some of this to really begin to look differently at some of the hardest stuff that any organization faces, like risk of suicide. Similarly, putting some of our information into Innovance Pulse has given us clues to signal despite the noise. So we've looked at a 4-fold, 5-fold increase in self-harm on some of our wards involving ligatures, but not ligature points. And this is something I don't think we'd probably have seen in the cacophony of noise that exists. But actually, it's made us really think differently about risk on our wards. And the implications as we gather more of this will be knowledge of methods, but date, time, location, staffing levels, medications, moods, what's the weather like? There may be loads of things which, with the 5 things that we can pick up on, that we can cognitively compute, we're never going to get there. But actually, if we can use AI to do this, we'll do it. So digitization is about people, not just the technology. And it's the iceberg thing. If we think it's about the above, having the values and the vision and the strategy and the goals, and we've got all of those. We've got all of those in spades. What we don't have is a mechanism to tackle the perceptions, the unwritten rules, the stories, the feelings, the fears that people have about taking risks with these things. So we need to think about user experience. And that's the difference. We can design the thing on the right, but people will do the thing on the left. And actually, why design the thing on the right when you could do the thing on the left? It's no more difficult than that. But precision, significance, and co-production, I fear in our clinical world, where we love science, we'll do what's on the left. We will get it precisely right. And actually, I think that's what our patients are saying to us, is tell me something that is actually significant to me. And guess what? If you ask patients, they'll tell you it's about the right-hand bit. Some of them might want the left-hand bit, but only some of them. So flipping the clinic and with people, these are our life rooms. Carnegie Library on the left-hand side, one in Southport down on the right-hand side. Doesn't say anywhere, really, that this is a mental health service. This is a place where you get on with life. And this is a place where you can flip the clinic. And we run our recovery colleges out of here, where you can have everything from an anxiety course through to a stand-up comedy course, if that's how you want to begin to think about challenging your anxiety. But the critical thing is, if we can get more predictive and we can use one of these, we can be pushing the information to people that they need, actually before they know they need it, if I can put it that way. Really, really important that we, therefore, not only create the context for flipping the clinic, but that we invisibly get that stuff going, getting the information to people that they need in a seamless sort of way. And sort of the last bit is, this is a bit that I sometimes wonder if we're really getting this, but it's the bit on the right-hand side. When stuff happens that we don't expect it to, we need in the NHS to move from asking the question, well, who was responsible for that? And we've all been there, we've all been in that scenario, to first ask why and how, and then start to learn. Don't reach for who. And I just want to acknowledge Otsuka, Relias Learning, who are our digital learning partners in what we do, as well as Serverlic, EMIS, JEC, and many others. So that's it from me.
Joe, thank you very much.